Okay. Hi, everyone. Welcome. Good afternoon. My name is Sally, and I'm the Program Operations Specialist at CoLab for Community and Behavioral Health Policy. On behalf of everyone on our team, I just want to say thank you so much for joining our webinar. So before we begin, I'd like to do a little bit of housekeeping. If you encounter any technical issues, please send us a message through the chat box, which is highlighted in red. And then we will also have a Q&A session at the end after the presentations. If you have a content related question, please feel free to send those using the Q&A function that's highlighted in purple. Please note that all content related questions will be answered after the main presentation. We will try to answer all of them during the Q&A. Alternatively, you can also raise your hand using the raise hand function to ask a question during the Q&A session, which is highlighted in yellow. And at the end, we will send an evaluation survey link through the Zoom chat. Please fill it out with any feedback that you may have so we can improve future webinars. We will also send out an email with a link to the recording and the evaluation to fill it out at your convenience. So without further ado, please let me turn this over to our wonderful director, Dr. Sarah Walker.
Thank you so much, Sally. We are so thrilled to have Dr. Lau Johnson and the panelists today, and really thrilled at the level of excitement that this presentation has garnered, and those of you who are here to participate in this today. I'm just very quickly want to say this is the second webinar in our evidence use series. So CoLab is focused on investigating and studying how the academic science evidence produced from universities and other sources, how that gets integrated and used in equity-informed ways in the real world. And just quickly moving to introduce Dr. Fong Lau Johnson, if you want to advance the slide. We're thrilled to have Dr. Johnson facilitating this today. She is a very valued team member at EBPI and CoLab. As many of you know, a respected expert and trainer in particularly trauma interventions, particularly racial trauma. And as you all can see in her bio here, she recently took a prestigious position with the National Center for Child Traumatic Stress. So we're so grateful that she agreed to facilitate this important discussion today. And I'm now going to turn it over to Dr. Johnson to introduce her talk and the other panelists. Thank you so much.
Excellent, thank you so much. So Sally, is this the slide from yours? And I'll just tell you when to go to the next screen. Is that what we're doing?
Yeah, that sounds great.
All right. Well, I just want to tell you a little bit about myself. My name is Fong Lau Johnson, and I'll be providing sort of a mini didactic for the first 20 minutes. And then we have some wonderful panelists, Seema, Laura, and Deacon, that will share some of their work with you all towards the end. We are hoping to reserve at least 10 minutes for Q&A and discussion. Really encourage folks to use the Q&A function. Just type your question throughout the webinar and discussion throughout, and we will get to them at the end. And if you have a specific question for one of us, you can say, this question for Fong or this question for Seema, et cetera, et cetera. Let's go ahead and go to the next slide. So currently, Dr. Sarah Walker mentioned, I'm the Assistant Director for Service Systems Program at UCLA. I wanted to put a plug that I previously conducted research on CBIS in the juvenile justice setting and created a racial trauma module. That official training is now available. I'm very excited about it. And I'm also currently developing a new program in collaboration with our OJJDP funders through Washington State called Transform. And it's trauma and racism addressed by navigating systemic forms of oppression using resilience method. One of the biggest things about this program is that we're being very intentional for having predominantly Black, Indigenous, and other people of color experts to develop this program. And we want to center BIPOC youth when we're thinking about how to develop this program. So if you're interested in that, all of our contact information will be available on the last slide. So feel free to get in touch with me if you're interested in either program. Let's go ahead and go to the next slide. I just want to introduce our panelists. We have Seema Matre from Odessa Brown Clinic at Seattle Children's Hospital, Laura Escalona Flores, she's a licensed clinical social worker at Neighbor Care Health, and Deacon Jones, who's the founder and CEO of New Develop Nation. They will be sharing more about themselves when they have their time to share a little bit about their work. Let's go ahead and go to the next slide. So, I thought a lot about how to put this sort of 20-minute didactic together for you guys. And so why should we focus on race and culture? And at the core, the focus of the social political contest is really critical. I've heard people say in trainings I've given, well, race is a social construct, and that's true. And it's also a social construct that was developed by white people long ago as a way to group people based on color. And it is absolutely true it's a social construct, and in a lot of ways has impacted the outcomes of these different groups that were arbitrarily formed so many years ago. So I do want to clarify that the differences in outcomes among racial groups are likely due to societal factors rather than differences in race or ethnicity. So one of the things I think is so important for us to be grounded in and to really understand is the concept of systemic racism. I think it bleeds through so much of a lot of our social political contexts. We see inequalities in housing, education, that impact people's outcomes. We see inequalities in employment, wealth, representation in leadership positions. We can find those roots in our history of slavery and segregation. It persists today. It actually even persists in evidence-based treatments and what programs are considered evidence-based. And I will speak a little bit more to what I mean about that. But when we think about who creates evidence-based treatments and who creates the guidelines in which what becomes qualified as an evidence-based treatment, and you look at the people who's at the table, they're typically not majority BIPOC individuals or people with lived experiences. So I think it's so important to consider the context and how these things are created, and keeping that in mind when we're thinking about the value of evidence-based treatment. Will they apply to the population in which you serve? And how can you make it work? And will it work with the population that you serve? So I think that's actually particularly important. I also want to point out that I am a fan of evidence-based treatment, and I'm also a huge fan of being culturally responsive, which I think is the priority. So I'm going to get to that in a moment. Let's go ahead and go to the next slide. So just in brief, our American population, we're having a significant growth in diversity in our population. Here are some of the numbers. There's significant heterogeneity among specific minority groups. When we think about Asian American, there's 20 different nationalities when we think of Asian American. Also 20 different origin groups when we're thinking about Hispanic or Latino. Something for us to keep in mind. Asian Americans in particular, and I'll get to that in a minute. There hasn't really been actually a single evidence-based treatment for children and adolescents that specifically look at the effectiveness for Asian American. And it can be broken up and thought of as East Asians or South Asian, both of which have very different experiences. And the same for Hispanic and Latino group. So also keeping that in mind is incredibly important. Let's go ahead and go to the next slide. There are significant racial and ethnic disparities in mental health. There are a number of reasons for them, and I want to speak a little bit about what those disparities are. And they can be rooted in things that can find its roots in systemic racism. Inequality to access, there are barriers to good health insurance coverage. We're seeing it today in terms of COVID vaccination. Whites are being vaccinated 4 times higher the rate compared to Black and Brown people. However, Black and Brown people are affected by COVID at 4 times higher the rate. So we are seeing disparities across the board, mental health, even in physical health. We're seeing it in our school systems and every single system that we can think of, child welfare, juvenile justice. So let's go ahead and go to the next slide. When we think about specifically mental health treatment, Whites consistently report higher rates of access than any other racial group. We're seeing African Americans and Blacks have poor health and health outcomes compared to white. We see Asians consistently report lower rates of access and wider disparities than any other group. And we're seeing the differences widen among Black to white and Hispanic Latinos to white, even though our population is becoming more and more diverse. Let's go ahead and go to the next slide. I thought these three statistics were particularly interesting. Hispanic and Latino youth are more likely to drink alcohol at a younger age than their African American and non-Hispanic Caucasian peers, but they're less likely to receive treatment for substance abuse. We're seeing African American youth show more symptoms of ADHD, but they're less likely to receive appropriate treatment for disruptive behaviors. In fact, we're seeing African American youth being disciplined for their behaviors at a much higher rate. And we're seeing the suicide rate among Native Americans been outpacing the rest of the country since 2003. It's the second leading cause of death among Native Americans. These are disparities that are so important for us to consider. Let's go ahead and go to the next slide. So why do they exist? There's a number of reasons that they exist. If we look at the workforce, which I'll talk about in a moment, it is predominantly white. We don't have enough providers that look like the population that are served, that have lived experiences or wisdom that can help with that cultural responsibility. That's one issue, okay? We also have issues with limited availability of specialists. I don't know how many of you all have tried to seek mental health services on your own, but navigating the insurance process is a monster. And I wish it wasn't so hard to find a therapist, but the system that people have to navigate even to get to a therapist can be really overwhelming. There are cultural barriers to seeking mental health care within Asian communities. All of these processes are highly westernized, and it can be really daunting to try and access care. Let's go ahead and go to the next slide. So what is considered evidence-based? So there are sort of like these criteria that are developed for evidence-based practice, and general evidence-based practice looks at design and methods criteria that are put forth in research studies. And they're looking to see, did you have a randomized controlled trial? Is your treatment program manualized? Do you have a specific inclusion and exclusion criteria? Did you use reliable and valid measures? And are the sample sizes and data analyses appropriate to detect reliable effects? So I just want to point out that even in those processes can create barriers for a good program to make it to this level, okay? So data analyses that are typically used are quantitative analyses, not so much qualitative. Reliable and valid measures. For those of any of my stats folks out there who are familiar with things like measurement and variance, that's actually a concept that's important to think about. We may create a measure, develop in English, and standardize it with an English-speaking population, but doing a simple translation of that measure doesn't actually equate to being culturally appropriate or responsive. So I actually just want to point out, we're already seeing some issues here that can create barriers for evidence-based treatment program to be appropriate for certain ethnic minority groups. And there are 5 levels that we think about when we think about evidence-based status and criteria level: well-established, probably efficacious, possibly efficacious, experimental, and questionable. Level 1, well-established, typically you have 2 studies that were conducted by 2 independent researchers, and they've met the design and methods criteria. Probably efficacious is that you've done at least 1 randomized controlled trial, and then possibly efficacious has similar guidelines, but it's less stringent compared to the other 2. Let's go ahead and go to the next slide. So I wanted to share what are the current EBT recommendations for things like anxiety, trauma, and ADHD. So there was a comprehensive review by Comer et al. In 2019, and I think we're happy to share these articles that I'm referencing here in this didactic for folks who are interested. And generally, what's well established is family-based CBT for anxiety, what's probably efficacious is group parent CBT and group parent CBT plus group child CBT. There's none that is possibly efficacious. And then we've got two in experimental, and then we've got relaxation training by itself as questionable. Let's go ahead and go to the next slide. For trauma, generally, there was a comprehensive review by Dorsey et al. In 2017, looking at what's well established. So individual CBT with parent involvement, individual CBT, and group CBT. And then we've got possibly efficacious with group CBT with parent involvement, eye movement, desensitization, and reprocessing. I want to be really clear that these are all child and adolescent recommendations. And you can see from the table here what falls in the other categories. Let's go ahead and go to ADHD. So in terms of what's well established, you can see in the table here what they've highlighted by Evans et al. In 2018. And you can see there's a number of programs that they kind of plugged into the different levels. Let's go ahead and go to the next slide. Now, doing, digging, okay, what about the samples in which these treatment programs were conducted on? Huey and Polo did a review back in 2008 or 2009, and they looked to see, what psychosocial intervention worked specifically for ethnic minority youth. And they recently did a 10-year update looking at what psychosocial intervention worked for ethnic minority youth now. And they added a representation criteria in addition to the design and methods and the evidence-based status criteria. What they were looking for is what studies actually have at least 75% of the participants with ethnic minorities. And that could reach the level of well-established. Overall, they only found 4 that met well-established, and we'll talk about that in a second. So let's go ahead and go to the next slide. So here's what they found. In terms of well-established, for Hispanic and Latino groups specifically, cognitive and behavioral strategy treatment programs are well-established, effective for anxiety. For disruptive, you have multi-systemic therapy for African American youth and family therapy for Hispanic and Latino youth. And for substance use, you have family therapy for Hispanic and Latino. You have none for trauma, none for comorbid, and none for suicidality. So there's 4 well-established for those specific groups. So I think that's really important to kind of hold on to for a moment when we think about what worked for majority minority population. Okay, so we have treatment programs that might say, well, I think my program, can be used for all ethnic minorities, which can be true. And I'm going to get to what you want to make sure you have in place before you take an EBT and decide I'm going to use it. But I also think it's important to see, well, what has been well established first for the population that I'm serving. Go ahead and go to the next slide. So here's the implication for clinical practice for ethnic minority youth. Your first line of intervention should be using those deemed well established. So the 4 well established that they mentioned earlier, you want to look into, can that be a good fit for the client that you're serving? If there are no well established, probably efficacious protocols are recommended. And you can see here what indicated for what's probably efficacious. Now, in the absence of probably efficacious, you want to consider immune, right? So you see the stepwise protocol here. At the last step, when nothing else works, you want to think of EBTs that have been tested for European American or white youth. They should be considered, particularly those that can be implemented with enough flexibility so that cultural adaptation may be applied as necessary. without diluting the effectiveness potential. That's really, really important. So I think these recommendations are critical for us to follow. EBTs are great, and I think it's the evidence that's been established is really important. It's much better than folks, kind of deciding to do random things. And I think it's absolutely important to be culturally responsive. Let's go ahead and go to the next slide. So where are the gaps? So we need more research conducted specifically with ethnic minority clients, representing the majority of the sample, not 10%, not 20%, the majority, 75% or more. We need more BIPOC researchers and developers in the field with lived experiences and wisdom, should inform the field and have power to make decisions. We need more programs developed for BIPOC population with them at the center and in mind. They need to be the sample in which you're standardizing these things on. And above all else, there's a strong need for cultural humility training among providers and more diversity in the workforce. In 2015, only 14% of the mental health workforce were BIPOC. Most graduate course trainings have maybe 1 or 2 courses in multiculturalism, and we absolutely need more community partnership engagement and research. Go ahead and go to the next slide. So what next? Ultimately, you want to be critical consumers, follow the guidelines, definitely do not make up your own treatment without testing it first, but be critical consumers. And above all else, make sure we're building your level of cultural humility. If you have a hard time understanding, explaining, asking about systemic racism, asking your client, do you think you've been impacted by systemic racism? Do you think you have come from a family of historical trauma or have experienced intergenerational trauma? If you have a hard time asking those questions, that's a sign that you should probably try and get some consultation or training. Consider moderators such as acculturation level, language, socioeconomic status. How do those impact an individual's development? Those are all things we want to consider. And we need more advocacy and systemic change. So those are the things I want to leave you all with and try to pack that in to a quick didactic. I'm so excited to introduce our first panelist. Any questions, thoughts, concerns, feel free to drop it in the chat or put it in the Q&A, and we'll have a discussion at the end. So let's go ahead and go to the next slide. And Laura, you are up next, and so excited for them to hear from you.
All right, thank you, Dr. Johnson. So this first slide, so my name is Laura or Laura, either one. I am bilingual, so I go by both. I put a couple just markers of myself. I think these are ways I would describe myself: Indigenous Mexican American, first generation born. And I think these are important to be kind of explicit about. These are filters that I view the world with, and I think that the world views me through also. And currently I'm the mental health clinical manager for the school-based program that Neighbor Care runs, predominantly Seattle area. You can go next slide. So ever since Dr. Johnson kind of asked me to participate, I was kind of asking myself, like, what is it that makes me, a believer in evidence-based practices, or have had experience that, at least, gives me some confidence in them? It kind of boiled down to a few things. Repetition. I've been able to do a lot of treatment modalities, so like TOCBT, for example. And I would say that being able to do it over and over and with different folks and with different experiences with it, I was able to really build that confidence. And I think that's a huge piece to all of this. Another big component I would say is really believing in the people, believing that they deserve quality healthcare, that, I'm just a facilitator of this, not coming from a stance of saviorism. So kind of understanding that it's not just like they need me, right? It's like, how can I support them in achieving what their goals are, and understanding how this world works, that there is institutional racism, that folks are coming to treatment with a lot of these things, right, that maybe can't be like as tangible. And then also just the consultation piece. So I think moving forward in any sort of treatment, it's important to be able to have consultation, have that reflection, support, question, plan ahead, think through. So but I'll touch on these things throughout my presentation. Next slide. All right, so how did I even like come into the world of EBPs? So some years ago, I was working at Harborview Center for Sexual Assault and Traumatic Stress, and some of you know that name has changed. And this place is a trauma outpatient clinic connected to Harborview, right? And so it's all CBT. But prior to this, I don't even know that I learned CBT in grad school, to be honest. So when I came into this, I was just like, what is this? Am I going to be able to learn it? Especially being trauma specific, I was like, am I going to go home crying every day? Because it's just going to be too traumatic. And soon I learned about the different modalities. So like I said, trauma-focused CBT, PCIT, AFCBT, cognitive processing therapy, and prolonged exposure. Those are kind of like the main modalities that I was able to learn and practice there. So yeah, that's how I learned it. And having that I worked at Harborview, I worked with essentially toddlers because of PCIT all the way through adulthood. So across the age spectrum, across language and culture. So I got a lot of experience from Harborview, and then I've kind of adapted it since then, I would say. You can go to the next slide. So after Harborview, sometime after, I came across a role for a school-based position. And I just thought it was great because I love working with teens. And I just had this theory that there's probably a lot of like undetected trauma in schools, and a lot of students of color that maybe hadn't had access or maybe have more barriers. And so I was super excited to go into school-based. And it was just kind of this perfect marriage of, I'm a social worker, so a marriage of like social work and public health. And when I got to school-based, I definitely, I think my hypothesis was right. There was a lot of counseling needs. And again, I think the beauty of school-based is you get such a wide variety of students. You get those that are like, I'm ready, I need counseling, I know what I want. You get those that are like, what is counseling? I don't like counseling, we don't do counseling. And so there's definitely that variety there, and you get such access to them, right? Because that's where they spend the majority of their time. And so some of the key things I have found to work or to really be a part of EBPs in schools is the family component piece, for example. And just to be clear, like I think there's, I don't know that there's not just one thing that works for everybody. So I definitely hold on to that, that reality also. The EBPs can work for some folks and maybe not for everyone. But one of the things, especially for like trauma-focused CBT, it definitely pulls from like family systems theory, right? And just like this family involvement piece. And I think that is huge. Like that's not specific to one culture. I think actually a lot of communities of color, that's a big piece to like our lived experiences. So I think that piece is huge for EBPs and like why maybe it can work. I think it's important to allow for room for doubt, especially if it's something that's not maybe as relatable to that student's experience, finding ways to like connect examples of cognitive or like thoughts, feelings, behaviors, but really just being okay with the doubt. And like those things that I put at the beginning of, like how I identify, I think those things allow me to hold multiple truths at once. So yes, like I can provide an evidence-based practice, but I can also question it also. And I think that just kind of comes from being like bilingual, bicultural also. It's not so black or white, there's a lot of gray. And I think there is room for creativity. EBPs, I think, often are viewed as like, it's so manualized, you can't do anything outside of this. But really, I think with skill and practice, you can incorporate some things. And obviously, like there are case management needs that our patients face, right? We can't just ignore that. And I'll try to give some more examples about that also. And go on to the next slide. So cross-cultural implementation. I've used this game so many times. So emotional bingo, if you're not familiar with it, it's basically just bingo, but with feelings. And this one in particular has like Spanish and English on the back. And so when I've worked with students that maybe don't speak English, this is a great actually like activity because it not only just does it support their like feelings vocabulary, but like their English language acquisition skills also. And just an example from here, I was working at a school for immigrant refugee students, and we had a student of Asian descent and had some self-harm and some cutting, and I was able to get the family involved. They were able to come in. I needed an interpreter for both student and the family. And we were able to play emotional bingo. And it was just great because even with a phone interpreter, we were able to engage, and the parents just being there and present and engaging with their youth, I think was really powerful, right? For that youth to say like, oh, my parents care. This can kind of open up conversation for other things. And so I think I just use that as an example of like that family component is significant because we are not, we're just temporary. We're not going to be in these students' lives forever. So, or any patient's life forever. So I think using things where you can kind of draw back from their social supports. You can go on. So as I said, it's important to have room for doubt. I always ask my students, like, do you think this will work? Especially if we're like really going to do an evidence-based treatment. And a lot of times, even when I've worked with adults, they'll say, no, I don't think this will work, or maybe, because nothing else has worked. So that's why they doubt. And I think, yeah, that's true, right? Like, because if you could change so easily, you would have done it already. So there's a lot of reason to not be so confident that it will work. And I think it's because I'm okay with that, and being like, okay, well, even if it's a maybe, like we can work with that and just kind of go from there. We'll check in to see if it's working. And if it's not, we might pivot, but let's try it out. And I think that's a lot of it. I think people sometimes get scared, like if it's maybe like quote unquote not working so fast or whatnot, people maybe shy away and just kind of abandon it. And also just this need to kind of weave their personal things in, right? Like I had a student and I was doing more of prolonged exposure, and the youth also had kind of some legal needs. So we were trying to access the police report and whatnot. And I thought that was really important to incorporate because one, it did kind of count as exposure. And also it was something that would maybe allow them to get like crime victims compensation or other things like that. So I think it's important either it can be a part of the treatment and it can just be like meeting those needs. Next slide. I feel like my time is going so fast, but really what this boils down to for me is access and opportunity. Like if we know something might work, why would I kind of withhold that, right? Let's try and let's practice it and see if this works and give them opportunity. I have these pictures up here because it reminds me of like diabetes, right? Like if we know there's a diabetes medication that works, why would I not share that information with you and let you decide if it'll work or not, right? And so if I decide like, oh, because this comes from, research that studied white communities, this isn't going to work for you, I've made that determination. I haven't allowed you to make that determination. Or also in this example of like diabetes, if somebody is more leaning towards like naturopathic remedies, like why wouldn't I just connect you to that? So I think it's important to be mindful of, this person has the opportunity to maybe like resolve trauma that will then allow them to live that life that they want to live. And also like, I think people are deserving of it, right? Like this community healing. This is one component of their life where they might get more power and control, and which also supports that resiliency because they're already dealing maybe with so much. Okay, I'll leave the rest for Q&A. I think that's it. Thanks.
Okay, so it's my turn. So I'm Seema, and I am a social worker at Odessa Brown Children's Clinic. We can go to the next slide. So I'm just going to tell you a little bit about Odessa Brown, just so you see the kind of the lens that we're working with at Odessa Brown. But it's a pediatric primary care clinic, part of Seattle Children's, and it's been in the central area for about 50 years, and it was really a grassroots community-led effort to make sure that there was appropriate care for the community at that time, which was in 1970, it was probably about 75% Black. And so that's like the purpose of the clinic really was trying to reach and provide service to a group of people who maybe didn't really trust service or trust the healthcare system. And so this was really the whole purpose is really to serve the Black and African American population. But so as you can see in 2019 right now, a couple of years ago, there's been so much gentrification in the central area of Seattle, and so our Black and African American population has dropped down to 14%. So people are coming to Odessa Brown still from really far away, from like Federal Way, Auburn, all the way to like Everett as well, like just all over King County. People come to Odessa Brown because they feel that sense of community. So we're still, even when I first started at Odessa Brown about 16 years ago, we were seeing about 60% Black and African American. And so we're still seeing about 40% Black African American, but it's definitely dropped because of the gentrification in the neighborhood. We see about 15% Spanish speaking and about 20% that are recent immigrants, and mostly from East Africa. And I guess I'm just trying to let you know that we're still really focused on serving this population that might have trust issues for so many reasons. And we're building a new clinic a little bit further south to try to get to meeting the population as they're moving south as well. You can go to the next slide. So the program that I work in at Odessa Brown, again, I'm a social worker. So I do general medical social work, but I also work in a Birth to 5 program. And what we're really trying to do with the Birth to 5 program is help create parent and child relationships and making sure that a child can have a positive relationship with at least one child, with one parent, at least one parent, which will really support their ability to go to school and how they'll be more successful, and then that can change the trajectory of all of their other relationships and their ability to engage with systems like the educational system. So right now we're working on a pilot program to screen for developmental and social and emotional skills. And I think that's why I'm here, is because I've been lately looking a lot at tools that we have for screening. We are collaborating with Harborview and with Child Haven, who have, in the last 2 years, have been working together. Child Haven has placed 2 family navigators at Harborview to actually do in-person administration of developmental and social emotional screening tools. And I'll say the reason it's such an amazing program is when they've hired people who look like the community, that come from the community. One of the family navigators at Harborview speaks Spanish and one speaks Somali, and Harborview has a very high immigrant population. And I'll also just say that they really, the purpose of it is really to allow these family navigators to talk to families, make them feel comfortable about why they're doing these why they're using these screening tools and why they think these screening tools will help their kids. And also, just if there's a need for service in the community, like getting 0 to 3 services in the community, then these family navigators will work to make sure that they're actually getting into that service. A lot of times, the 0 to 3 service is really hard to access. Like same thing, like even like getting mental health care, it's hard for parents to jump through the hoops to get into the service. So the Family Navigator program really helps to close the loop for those referrals. And I'm just going to say right out, I have not been someone who has been really interested in doing screening tools at my clinic. Sometimes I feel like it's a way to just check off a box that you've checked something, like you hand it to a family, the family fills it out, and then you can kind of say you've looked at it and you've done something. And I've been very much more a strong proponent of relationship-based care, like knowing that I've been able to be in my position for as long as I have really strong relationships with families. And I can sometimes meet a child at 5 days old, and now I've been there 16 years, so I can then have this really strong relationship. And I would assume that over time, I'll be getting the information I need to get about the family to help support with resources as needed. But what I've also learned is that sometimes that relationship that I might have with a family is can get in the way of making the right decision about what a child needs or what a what a parent might need. So I think I've really sort of come around to the idea that we do need to look at how do we get information in a sort of formalized way. But what I've found is so now here we are, we're looking to hire 2 family navigators, and we are trying to find people who represent the community that we serve here at Odessa Brown. And we are going to start administering certain tools. At Odessa Brown, we're going to really emphasize the social emotional skill development, in addition to developmental, but also just trying to really create a strong relationship between that parent and that child, no matter what the psychosocial stresses are that they may have, right? So just trying to figure out how to continue to grow those relationships. So I've been looking at tools, and it's been really sort of hard to figure out what's the right tool. We can go to the next slide. So there's obviously, just like what Dr. Johnson was talking about, is like there's a problem with validation, because who are the people that we are validating with? Like, who are the groups of people that we're validating with? Usually it's dominant white culture. And how relevant is that validated tool to a BIPOC population? It's not always as relevant. I think about there's a good example of a reading comprehension question, which asks the question something like, what 3 items do you not find in a would not be in the backyard? And there it's like the choices for the question would be like a lawnmower, a bunny rabbit, or a couch. It will say something like that, and you'll think that's an easy answer, right? Obviously, you wouldn't find a couch in the backyard, but then it doesn't think about, maybe you're a 6-year-old reading this and trying to answer this question, but you grew up in the city and you live in an apartment building and you've never had a backyard. So why would you know that a couch doesn't belong in the backyard, or what a backyard is, or just how things actually change, right? So you could be someone, or like you could live rural and live in a warm climate, and you might actually have a couch in the backyard because that is where people gather. But also the part that we just, like right now, there's so much of us spending so much time outside because we can't be indoors with anybody. And so there are a lot of different, like there's this whole section of like outdoor living where someone might think like the couch actually is outside now because that's where we spend all of our time in general. So just thinking about like how the validation happens amongst a certain population, it might not make sense for somebody who's reading that question right then, and things will be changing. And so how do we continue to go back to that tool to make the appropriate changes? I've been doing some screening tools as a little pilot with some families, and asking the question about your baby. How is your baby meeting new people? And so many of our families right now are saying, well, my baby's 6 months old. They were born in the middle of the pandemic. We've been isolated and we have no other. So I know this is not a permanent suggestion, but it really is the thing that things change, and that affects how we ask questions and who we're asking questions of. So then I also think about language translation versus cultural context. So like one of the things that makes me want to use a tool is if it's easily translated into a lot of different languages, and that I can access that. But I don't always know whether it's actually picking up on the cultural context that might be different, right? So I don't have that knowledge all the time. I think about the question that we ask sometimes for physical development when we're asking about, does your child use a spoon to feed himself? And the truth is, many people don't eat with utensils, right? Many of our families that we work with eat with their hands and eat in the community. also, that's what I just sort of wonder about, like, are we getting at the right people here? And then I also worry about questions that come that are deficit based and versus strengths based. And there's so many screening tools out there that call themselves strengths based, but for some reason there's just always this idea that like, is your child cranky, or is it hard to calm your child down? I sometimes feel like for families that are typically marginalized or may not trust us as well, may feel threatened by a question like that, or may feel like they're not good enough and we're judging them and we're not doing well by them, rather than sort of picking out like, well, what are the things that you do well with your child? We work really hard at Odessa Brown to just point out really the stuff we see in real time that families are doing, so that we don't get bogged down in this. And again, I go back to that idea of the family navigators that will be joining our team at Odessa Brown. A lot of what the work that they'll be doing is really mitigating harm that can be done by some of these questions, because they will have personal relationships and because they will maybe hopefully look like the community or have lived experience like the community. So I feel like that's a big thing. I'll go to the next question. I know we're running out of time, so I'll go to the next screen. These were just some examples of things that I saw that are on very, very easy to find and used screening tools. But like the idea of your child being fidgety or unable to sit still. Is your child angry? Does your child obey you? I feel like these words are sometimes really, really hard to speak in, especially with like Black and African American and other people of color. It feels really hard. We talk about generally well behaved and does what adults request. It's really taking away any kind of like internal motivation to live in this world, and it feels very, very dominant culture to me, these words. And I think that they sort of embedded in dominant culture, like what does well-behaved mean? And why is it so important for someone to sit still, right? Like, what does sit still mean? Does it mean they won't be able to learn because they're not sitting still? So that's hard for me to see. We can go to the next screen. This is just another, I can end with this. This is really just about, these are some of the words that come from the screening tools that I've been looking at. Like, so obey, comply, conform, oppose, like these are words that really have a lot of racism within them. And I think it's really something that we need to look at when we're doing these kinds of tools, using these kinds of tools with families of color. And I think we need to come at, when we're using these tools, coming at them with a lot of compassion and knowing that we're really trying to provide a needed service and not really make parents feel like they're doing something that is hurting their child. I think I'll end with that.
All right, Deacon. All right.
Hi, my name is Deacon Jones. I'm from Lapwai, Idaho. I was born and raised on the Nez Perce Indian Reservation. I'm Afro-Indigenous. And New Developed Nations, I founded over some years of trying to figure out how to have representation for the people that I grew up with. And so programming kind of started with trying to help youth get a voice. And while I was in high school, I was in a school to work program and started at the Boys and Girls Club. And I pitched this idea of utilizing music to get some stories told, because it's the tactic that I used growing up to be able to express my feelings, whether anybody heard them, saw what I wrote or anything. And so they gave me a shot to try it out. And the first thing that happened is we had a lot of disclosures coming up in the music. And these are 6-year-olds to 18-year-olds. And so we had to pull that back real fast. We weren't ready to kind of confront that being the Boys and Girls Club. So it took some years before I brought it to an inpatient treatment facility and requested the youth there. They were 13 to 18, boys and girls. And we had a panel, and we spoke to them and asked them what they need to be successful in treatment, because they were getting kicked out at a high rate for rule violation, running away, all these other things. And in every list that the youth talked about, there was some form of music. And so when I brought it to the attention of the executive director, they gave me a shot to try this program again. And as soon as we went off site to a studio, and I helped the kids write some lyrics, tell their story of how they arrived to where they were today, which was inpatient treatment. And the stories were super powerful. They were telling, they were insightful. They showed a whole nother level of ability that these youth had. And so the takeaway from that was we saw majority indigenous kids, but we had African American, white, Asian descendants, Latino, Latinx population. Every one of them that came, a lot of them had toxic shame and they were painfully shy. And they got back from the studio saying, listen to, this is me on this part. And, oh, I helped so-and-so write this part. And they were just really kind of changing the behavior in that way. And so that became implemented into a daily treatment program there. And we started they interviewed me on why I did it, what I did, why I wanted to do it. And for me, it was really language, because in one case, I had a kid that it was co-occurring disorders, and they had cognitive disabilities. That's what he was listed with. And as soon as I bring him into the studio, I brought the executive director up and I said, I just want you to watch him record. He recorded, he made a mistake while he was recording, and he came out of the booth and I was recording him, and he said, can you take me back 8 bars, punch me in, I'm gonna redo that line and then I'm gonna double it. And I said, yeah, sure. And he went back into the booth, and the executive director was like, we have to reevaluate how these kids are diagnosed as well. These aren't, they're cognitive disabilities or anything. These kids are brilliant. They just need a voice to be able to express. And so I tell people that the program that I developed is it's really just a launching pad for a voice of kids and adults who haven't been heard before. And I like to talk about cultural language extending beyond ethnicity, even at times when you have somebody that represents you in the field, the slang, ebonics, mannerisms, all these other things that often go unnoticed can be picked up. And so I'll have a kid who will say something like, but the motivation is the glow up, right? And people are just like, what does that mean? And they're like, never mind, I don't want to translate everything that I say to you because we don't speak the same. But in a small statement like that, I can understand that we need to work on the thought that money and materials are the key to happiness. And so it's just one simple line can get to these root issues of where rule violations now become treatment plans. So in a case of that, we had a kid that was hoarding snacks and was getting in trouble every time he stole snacks from the cafeteria, and he kept getting rule violations and losing his privileges. And in through the song, reading his lyrics that he wrote, I realized there may be food trauma. And so I talked to him more around the food trauma, and we find out this is a major barrier in his life and his upbringing. So the entire facility shifted, and now we're treating from a whole nother lens. And that's more of the things that I'm hoping to spread across to everybody else. Because if there's things that I don't have anybody to really refer to the clients that have other needs culturally. And I'm in Spokane, Washington now. And so figuring out a way to hear, translate, and understand people that come from different cultures, I feel is one of the biggest barriers to treatment. And so healing through hip hop, and we do all genres of music. We've done all genres. We do journaling. We also do the spoken word and poetry and all of that. And so in the music, just finding out who this client listens to will tell you who they culturally connect to. And once we learn about these artists that they revere and we play the music and ask why they love them, now we're learning more about these individuals and how they operate. And so if we can go through the slide and get to the music. I know the time is a little short. Here it is. And this is an example of one of the kids that I've worked with who said that he can't rap, said that he doesn't want to rap. And and I get that 9 out of 10 times. So, but we find out that everybody loves music, and we find a way to speak with them to get these projects complete. I think it's the next slide. Oh, after that. Oh, if you push the next slide, will it play? Or will it just, I don't know. Oh, okay, I guess it's not gonna, I don't think that it's gonna work. So a lot of the, I guess, lastly, I'll leave with working with Indigenous youth. A lot of times me showing up and saying, when they ask where I'm from the reservation. A lot, even just that little piece, they'll brighten up. So, which res are you from? I'm like, the Nez Perce Reservation. Like, oh, I know so-and-so from there and here. And next thing you know, our conversation has flowed into an entirely different way to go about things. So we'll just, I know right now it's 101, so we can stop there and just go to the Q&A.
Deacon, thank you so much. And I really wish the music would work, because I think it really it ended that presentation so nicely. And so let's go ahead and hop into the Q&A. I was trying to answer some of the questions, but let's just go ahead and start our Q&A. And we know folks need to hop off right at the hour. I want to thank everyone so much for their time and energy and their interest in the topic, which is so important. Some of us can hang back for another 10 minutes to do the Q&A with you all. If you want to hang back, feel free. And this will be recorded as well, so folks who missed it can watch it on their own. So one of the questions is, in some cases with clients, work with insurance companies to specify the necessity of using EBPs in treatment, even though at times they are not culturally appropriate. Do you have advice on how to justify adjusting an EBP so as to both appease the insurance company and tailor treatment towards our client needs? And so I can answer in brief, and I'd love our panelists to share their experience as well. And typically, I don't think it's not so much needing to, you can still check off, right? Like you're using CBT for anxiety. How you are culturally responsive is in the work that you do individually with the client. And I don't think you need to justify adjusting the EBP for the insurance company so much as you need to ensure you're still using the core elements of CBT for anxiety, but where you're adjusting, it's culturally responsive for the client. So holding both those balances are really important. Anyone else on the panel want to chime in on that?
I would just ditto what you said. And I think also, you know, if you're starting CBT and just doing kind of like general psycho ed, you know, coping skills, things of that sort, I mean, you're falling within that EBP, and sometimes also that's all people need. Sometimes you'll see people get like those first components and then they're kind of like, I'm done, I'm better. Like it's so huge for them to hear like, I'm not the only one going through this, or this explains why I'm feeling the way I'm feeling. So I think there's some flexibility there. So yeah.
Absolutely. Thank you so much, Laura. Thank you. We have a question from Heather. I am curious how this information should be applied towards Indigenous Native North American youth. I am Native myself, Cherokee Nation, and so understand deeply how rare Native clinicians and social workers are, as well as the ways that racism, erasure, tied to colonization specifically impact Native youth, especially considering the fact that we have more than 400 Indigenous tribes throughout North America with so many distinct cultural experiences. I am curious if you know of any pathway currently moving toward evidence-based modalities using Indigenous research methods, which are specifically interested in using storytelling, multiple truth, circular and holistic practices, and worldview embedded within research practices. I know our struggles and experiences as racialized folk are both connected and distinct, but would love to hear what you know and can share about North American Indigenous EBPs, or at minimum, how to embed culturally relevant practices within services, especially cross-culturally. So what a wonderful question. I have some thoughts, but I want to actually, if any of the panelists want to chime in on this one first, I'm going to just pop in the chat a resource. If anyone wants to take a stab at this first. Laura, Seema, or Deacon. I feel like it's a very specific question, especially with research and how to use methods. What I will say is that I think slowly the field is trying to really examine our data evaluation method, and how sort of Eurocentric the process can be, and how can we honor more quote unquote non-traditional methods such as storytelling, multiple truth, circular and holistic practices. I put in the chat a resource that was a woman, Dr. Alicia Musal, that I presented with, and she gave this wonderful presentation about how their center adapt EBT specifically for Indigenous population that centered out of Montana. So I can provide some resources and connect folks to Indigenous researchers that have found a way to have their program be standardized and considered as evidence-based. Also, folks who've been able to adapt current EBTs and make it work for their populations as well. I'm thinking about the lack of efficacious treatments for comorbid disorders for Black, Indigenous, and other people of color. How would you approach this? Meaning, what would you prioritize in treatment? Where would you begin? Seema or Laura or Deacon want to take this question?
Hold on, let me reread the question. Where I lost it. Can you repeat the question? I completely blanked on it.
There's a lack of efficacious treatment for comorbid disorders for BIPOC individuals. How would you approach this? Meaning, what would you prioritize in treatment? Where would you begin?
Yeah, I mean, I guess I would, with a good assessment of figuring out kind of like what's driving the train, right? Is it substance? Is it, anxiety? Obviously, it's something's really hard to tell. But I would think about, what's kind of interfering the most. What are their goals? Obviously, asking the patient or the client. With certain treatments, it's like if somebody's actively self-harming, for example, you wouldn't want to start the treatment, right? Because they don't have the skills yet to deal with like they're being triggered. And And I think it's just important to assess for both and really kind of give that psychoeducation about how these two might be interplaying. And just even asking students and giving them that feedback or patience. I think there's just a lot of value when people hear that feedback of like, oh yes, there is substance that I'm dealing with and it's impacting me in this way. And this is how it might be kind of contributing to the depression. But again, I guess just asking and assessing, and sometimes with trauma, when there's like more than one trauma, I ask like, which one's the one you least want to talk about, right? And that way they're like, and that's usually the one that maybe we should work on, but we might start slow. So yeah, I'm not sure if that fully answers it.
I like that, Laura. Thank you so much. I think a related question is, due to EBTs being made by mostly white folks and the societal pressure that they're quote unquote right, can make it difficult to question the order and process of an EBP in order to be able to be flexible. How can we trust that our flexibility will work? And I think ultimately, you can trust your flexibility will work if you stick with the core ingredients of that treatment model. So we know like CBT for trauma, for example, has some core element to it. You know, psychoed, relaxation, cognitive coping, cognitive restructuring, problem solving, and relapse prevention, right? And exposure. You know, if you take out like 2 or 3 of those components, you're actually no longer doing that EBT. You're doing something that you're kind of making up on your own. Flexibility is to the point where if you want to teach them about trauma, for example, but you want to do it in a different way. Maybe you do it through media. Maybe you do it by sharing a story of someone else. But you do it in a different, and then that's where the flexibility is actually available in a lot of the EBTs, and really want to emphasize that. So I think you can trust it will work if you keep your core and active element of that treatment program. Anyone else want to chime in on that from the panel? Okay. Deacon, are there music therapy group for BIPOC kids, teens in King County? Have so many clients who would love programs like Deacon's. Deacon, are you aware?
I've heard that there are. It's usually in passing where someone says, oh, there's a program that's similar in Seattle, and I wasn't sure the name of them.
Mm-hmm.
But what I am doing is trying to become an evidence-based trainer in practice, so I can go into schools and train our generations that are coming out of college to do exactly what I'm doing and kind of grow this thing. So I think that's kind of into the other question where they're talking about bringing storytelling and other indigenous practices into the EBP scene, and hopefully we can get that accomplished so we can make it normal for us to say these things have been working for us for a while now, and we just need that stamp.
Absolutely. Thank you so much. And perhaps we can put some resources together. I know there's a trauma program called Hip Hop Heals. I know the first name is Dr. Jaleel. I don't remember his last name, but these programs exist, and I think it's about elevating them. And like Deacon's program, you've been working on this for how long now?
About 12 years.
And it's just about elevating, work like Deacon, who's been on the ground doing this, developing it. And so I think what can be useful for us to think about is putting together some resources and a list for people who've registered for the webinar to consider what are the other programs available out there. Let's take a couple of questions. How have you found success in getting other providers or you maybe working with to buy into applying EBTs from a culturally responsive lens? Seema, would you like to take this one? Is Seema still here?
Yeah, I'm here.
I know
I
we're
have-
working back a little
No, no, no.
afterwards, so I appreciate you hanging back. Thank you.
No, I just feel like I'm not a therapist, so I think that's why I haven't been really answering. But what I would say in our clinic, we're so lucky to have medical providers who are willing to look at something different and how to provide healthcare to families, and mostly families of color. And that's that whole relationship-based care. So I'm so fortunate that I get to work with people who are really interested in that kind of work, which is really shifting the way you provide pediatric well child care. But it's been a slow moving to get people to that place where that's what they want to do.
Absolutely. I feel like we've reached a point where you can't ignore it, right?
Mm-hmm.
I mean, we need to be culturally responsive. We see the effects, and we just can't ignore it.
And it like really speaks to their own satisfaction in their jobs. Like if they feel like they're hitting their head against a wall when they keep talking to families in a certain way, then you don't really feel satisfied in what you're doing. So how do you shift what you're doing to also get that satisfaction?
Absolutely. With regard to screening tools, would it be considered ethical to modify the screening questions in a way that would be more culturally appropriate and less harmful?
That's something, I mean, we've thought about, or we do things like take art portions out versus changing the way the question is formed, because then that takes away the validity of it, right? So we're not really allowed to do that. And that would be kind of like making up our own thing, like you mentioned, Dr. Johnson. Yeah. So we're trying to stay away from that, but maybe take out a portion of kinds of questions that don't seem fitting.
Absolutely. I think you can, I think it depends, right? Like I know, for example, like there's a social emotional questionnaire and I said, do you hear voices? And I remember I had a kid once like, yeah, sometimes I hear my grandma. And it really wasn't a big deal to the kid, right? And he's like, but if I took it so little, I could be like, oh my gosh, that's like an auditory hallucination. And that's, we don't want to go in that direction. So I think in that way, right, we can kind of probe more and ask more, okay, what did you mean more? Like, can you tell me a little bit more about you hear your grandma? So I think it's so case dependent.
I feel like you're using a cultural lens to assess, right? In that moment, you're not just taking that as a straight answer, and then that means that you go down this path. You're really using that cultural lens.
Absolutely. Well, thank you so much, everyone. I actually found a way to play Deacon's music. So I am going to, we're going to end the webinar now, and we'll collect everything. Again, the recording will be sent to everyone, and we'll type in our responses to any, I think we got to actually to a lot of the question. And so I am actually going to, let me find you guys. Okay. Yeah.
Also, this youth who did this song, he said that he can't rap. He doesn't want to rap or try it or anything, but there was a nationwide competition from the Grammy Foundation, and they asked for kids to tell their stories about addiction or trauma. And so there was thousands of kids that submitted, and he ended up winning like second place, and they flew him out to the Grammys. He got to meet artists, and it was his first time ever on a plane. And he was like, it shifted a lot. It showed him that there's a lot that he can actually accomplish.
Absolutely. Thank you so much, everyone. Hope everyone got a chance to jot our contact info. We like to close out with music, and wish you all a beautiful afternoon. And thank you all for doing this important work with our children, our families, in our community. And we hope to connect again soon.
Here we go, blast off. Here's the story of my addiction. I was never a kid to really take the time to listen. So when I was told to stay away from that crowd, I did the total opposite. And look at me now, 5th grade. I started hanging with the crew. Parties every weekend and my mama never knew. Still in the cash so I could purchase a bottle. I was headed down a dark path to smashing the throttle. I was getting in fights, I was learning the game. Breaking the law was now an everyday thing. Residential birds selling weed by the OZs. Beating fools down, man, just cause they own me. I knew it was wrong, but I just did it for the set. I was told to go big and don't settle for less. I changed my style, even changed the way I dressed. But I had no clue that my life was a mess. My life was over until I got sober, but I found another way to get through this life. My life was over until I got sober, but I found another way to get through this life. The drug took control and I acted a fool. At the end of 8th grade, I got busted at school. I sold a bag to some preps, they got caught with the smoke. They straight snitched me out, man, it ain't no joke. I got a Class C felony, got sent to detention. It was like a new world, unseen dimension. When I got out, it was the same old thing. Stealing for bud and being a fiend. Then I messed up again and got sent to rehab. 28 days just made me even more mad. After that, I was in and out of jail. 3rd time struck and I was tired of life in the cell. Made a choice to change, take the life of sobriety. The thing I want most is for my fam to be proud of me. 90 days treatment, healing lodge of the 7 nations. And you better believe that I'm a proud patient. My life was over until I got sober, but I found another way to get through this life. My life was over until I got sober, but I found another way to get through this life. That 90 days was the hardest thing I've ever done, but I conquered it, and I still had fun. I learned a lot, and even got some self-healing. Now I ain't numb, I got back my feeling. Change the game, but I can change who I am. And best believe that I'ma do the best that I can. Substitute drugs for this lyrical part. And make time for my flows, make time for my family. Got good intentions, got love for my life. I'm tired of institutions not knowing when I'm gonna die. Just know, if you want to succeed, it'll happen if you want it. Just chase your dreams. You gotta make sure that your senses are keen when you're picking the new cats that'll be on your team. Now I'ma give a shout out to God and my moms, cause if it wasn't for them, I would still be lost. My life was over until I got sober, but I found another way to get through this life. My life was over until I got sober, but I found another way to get through this life.
Wow, Deacon, thank you so much for sharing that with us.
Yeah, thank you. Thanks for having me. I appreciate it.